So in our previous lecture, we saw about the cystic disease of the kidney. In the first lecture, we saw about adult polycystic kidney disease, that is autosomal dominant, which is more common in the adults. In this lecture, we will be looking at childhood polycystic kidney disease, that is autosomal recessive. Moving on to the autosomal recessive polycystic kidney disease, that which happens in the childhood. Now this childhood is divided into 4 different periods. Okay, childhood is defined into 4 different periods. It could be perinatal. Perinatal means the intrauterine life 28 weeks plus 7 days postpartum. It could be neonatal. As you all know, neonatal period is the 0 to 28 days. Okay. Then we have infantile. Infantile period is 28 days to 1 year, followed by juvenile. Juvenile period of autosomal recessive polycystic kidney disease is from 1 to 6 years. One thing you should know that the disease that affects the perinatal and the neonatal period is the most common, as well as it is associated with serious manifestations. So whenever there is polycystic kidney disease autosomal recessive that affects the childhood, it could be divided into 4 different period of childhood, that is perinatal 28 weeks to 7 days, neonatal 0 to 28 days. Along perinatal and neonatal are the most common type, and they are associated with most common serious manifestations. It can also affect the infantile period as well as the juvenile period. These serious manifestations will ultimately lead to the child can succumb to death, as well as the child can progress rapidly to renal failure. Okay. Now, what is the main pathogenesis behind the childhood polycystic kidney disease? We'll look at that. Pathology. So predominant pathology that happens in the autosomal recessive childhood polycystic kidney disease is there will be mutation. Mutation in what? Mutation in PKD1 gene. PKD1 gene, which is located on chromosome 6q21. And this gene is associated with protein called as fibrocystin. Okay. The predominant pathology here is PKD1 gene, which is located on the chromosome 6q21, and it is associated with the protein called fibrocystin, and it has a similar mechanism of action as I just told you in the adult polycystic kidney disease, how it leads to polycysts in the kidney. So please watch that lecture. Moving on to the morphology of childhood polycystic kidney disease. Morphology. Okay. The kidneys will be enlarged, but it will have a smooth cut surface. So this will be the outer morphology of the kidney. Kidneys will be enlarged and it will have a smooth cut surface. In the kidney there will be numerous small cysts will be present. So this is how the morphology of the childhood PKD will look like. Now moving on to the clinical features. So clinical features of polycystic kidney disease in the childhood. Okay. So what are all the clinical features? The clinical features are almost similar. They are almost similar to adult polycystic kidney disease, that is ADPKD. We will go over the clinical features in the ADPKD. In the ADPKD, the patient will be asymptomatic up to 40 years. Slowly, the patient will have azotemia with slowly progressing uremia. It will also be associated with hemorrhage and progressive dilatation leading to flank pain. There will also be excretion of the blood clots, also associated with renal colic. On per abdomen examination, the patient will have palpable bilateral kidneys, and the hematuria will be insidious onset and progressive towards the CKD will be done. That is whenever there is proteinuria less than 2 grams per day along with polyuria as well as hypertension. And these are the associated extrarenal anomalies seen in ADPKD. Okay, so these clinical features are almost similar to the childhood PKD. In this, almost all the cases will have liver cysts. Almost all the cases will have liver cysts, and this is also associated with bland periportal fibrosis. Okay, it's also associated with bland periportal fibrosis along with proliferation of well differentiated biliary ductules. Okay, and this ultimately leads to portal hypertension with splenomegaly. Of the child. So this combined features is known as congenital hepatic fibrosis. So this is one clinical feature that differentiates ADPKD with childhood PKD. Almost all the cases will have liver cysts. It includes the bland periportal fibrosis along with proliferation of well differentiated biliary ductules leading to portal hypertension with splenomegaly. So this is all about the childhood PKD. Moving on to the other cystic disease of the renal medulla. Okay. Moving on to the third type, that is the medullary sponge disease. Medullary sponge kidney. So this is the third type of cystic disease of the renal medulla. In this disease, there will be multiple cystic dilatation of the collecting ducts. So there will be multiple cystic dilatation of the collecting ducts. In the renal medulla. That's why it is called as the medullary sponge disease. It mainly affects the adults. In this case, the patient will have normal renal function. So renal function is not affected. But when we look at the morphology, we can see dilated papillary ducts on medulla. So these are the classical features of the medullary sponge disease. The fourth type of disease we have is nephronophthisis. Let's look at nephronophthisis. Okay, what is nephronophthisis? They are group of progressive renal disorders. Characterized by variable number of cysts. In the medulla as well as corticomedullary junction. Okay, nephronophthisis is defined as a group of progressive renal disorders characterized by variable number of cysts in medulla and as well as corticomedullary junction. This is the most common genetic cause of ESRD in children as well as the young adults. So nephronophthisis is the most common genetic cause of ESRD, that is end stage renal disease in children as well as young adults. Okay, now let's look at the pathogenesis of nephronophthisis. Moving on to the pathology part. In nephronophthisis, the genetic mutation is mutation of NPH1, NPHP1 to NPH11, and these genes are associated with nephrocystin protein. Nephrocystin. So this is the main mutation that is associated in nephronophthisis. This will lead to initial injury to the distal tubules. So we can see initial injury to the distal tubules along with tubular basement membrane disruption. So there will be mutation in NPH1 to NPH11, that is they will synthesize nephrocystin protein. This leads to initial injury to the distal tubules along with tubular basement membrane disruption. This further leads to chronic progressive tubular atrophy. Chronic progressive tubular atrophy. Finally, this leads to cortical tubulointerstitial damage as well as fibrosis. This finally leads to cortical tubulointerstitial damage along with fibrosis. Okay. So what do we have in the pathology of nephronophthisis? The patient will have mutation of NPH1 to NPH11 genes. This leads to defective synthesis of nephrocystin protein. This leads to initial injury to the distal tubules along with tubular basement membrane disruption, finally leading to chronic progressive tubular atrophy, and the patient will end up in cortical tubulointerstitial fibrosis as well as damage. So this is the basic pathology in nephronophthisis. There are three different variants of nephronophthisis. We'll look at them. The variants of nephronophthisis. So three different variants of nephronophthisis are: number one, sporadic non-familial. Sporadic non-familial variant. There is B, familial juvenile nephronophthisis. Familial juvenile nephronophthisis. Okay. And the third variant is called as renal retinal dysplasia. Renal retinal dysplasia. This is the most common nephronophthisis, that is familial juvenile nephronophthisis, and this is associated with ocular lesions. That's why it is called as renal retinal. So this is associated with ocular lesions in the patient. Now moving on to the clinical features in nephronophthisis. So what are the clinical features that we have in nephronophthisis? We'll look at that. The patient will have polyuria as well as polydipsia. Polyuria along with polydipsia. There will be defect in concentrating ability of the urine. So the patient will have defect in concentrating ability of the urine. There will also be sodium wasting, Na plus wasting, as well as the patient will also have tubular acidosis. Okay, these are the main clinical features. The patient will have polyuria along with polydipsia. There will be defect in concentrating of urine, so along with sodium wasting as well as tubular acidosis. So what are the extrarenal features associated? Extrarenal features associated with nephronophthisis. Okay, The patient will have oculomotor abnormality, along with retinal dystrophy, okay, followed by the patient will also have liver fibrosis along with cerebellar abnormalities. The progression to end stage renal disease will be around 5 to 10 years. The progression to end stage renal disease will be in 5 to 10 years. So this is all about nephronophthisis. Thank you guys. Thank you for watching. Subscribe and share if you found it helpful.